Yeah.
I used to work in Alton and the Wellington, which are senior living facilities, and I
Okay.
referred every single family to your drugstore because the service was unbelievable. So,
Well, thank you. That's great. That's what we want to hear. That's our entire goal.
yeah.
So yeah, we work with a lot of people at the Wellington. So yeah, like Kathy said, really happy to be here. Thank you for showing up. We're excited to talk to you about this. My dad and our owner, operator, boss man, plumber, head vaccinator, what have you, pharmacist too, John is also on the call. So you probably see him on there. Thank you for the peace sign. So he's probably going to weigh in at certain points on this presentation or help out with Q&A at the end, because he really, at the end of the day, knows even more than me. But this is just something that I've kind of started doing related to my work I'm currently doing at the pharmacy, is giving presentations like this. So that's why you have me. And also I'm the nurse. So no offense to pharmacists, but go nurses. Um, so I'm going to share my screen now. Okay, we'll do desktop. Sorry about that. I just got to fix a setting quick. Okay. Okay, hoping this will work now. All right. Okay, can everybody see okay?
Yep. It shows up
All,
just
all
fine.
right.
Thank you.
Awesome. Okay, so I have a lot to talk about, so I'm going to try to be as efficient and detailed at the same time as possible. We will have time, hopefully, for Q&A at the end. But here we go. So, like I was saying, and Kathy was saying, my name is Hildy Hessian. I am a proud nurse, like all of you, as well as the mail order coordinator and creative director at my family's independent pharmacy, St. Paul Corner Drug. And my presentation today is called The PB Mafia: How PBM Abuse is Shaping Our Health System and What You Can Do to Help Combat It. Yeah. So this is just an agenda for what we're going through tonight. I'm going to start with an introduction, who we are and what we do at St. Paul Corner Drug and why I am giving this talk. Kind of the meat of the presentation in our second section is talking about this PB mafia, we call it, the PBM industry, who they are, what they do, what they don't do for our health system, and how they are intimately connected to the fast approaching, I hope, not ultimately death of independent pharmacy in our nation. Then we'll move on to talking about more like big picture, how this is related to not just the pharmacy industry, but really our whole health system and how it is not really functioning so well these days. And then the last part of the presentation will be kind of a brief explanation about the different things we would like your help with. And then we'll end with Q&A as we have time. And I just want to throw out there, I will share my email address at the end of the program or a presentation, and I am more than happy to field any questions that you have that we don't get a chance to talk about tonight. And then Kathy and I together came up with these objectives because it sounds like there's continuing education credit potential for tonight. So my goal is that by the end of this presentation, you will be able to define the role of a pharmacy benefit manager. You'll be able to describe how a PBM can negatively impact our healthcare system. And lastly, you'll be able to identify ways to combat PBM abuse through patient education and legislative action, especially. So first, brief little introduction. So this is a picture of where John and I work, St. Paul Corner Drug. Our family owns this store as well. We are a fifth generation family owned independent pharmacy, which has been operating in this space since 1922. I think my parents bought it in 99. Put the right date in the chat, Dad, if I'm wrong. As you'll see here, there's a list of all the different services we provide, and it's not just filling prescriptions, it's all different sorts of stuff. In particular, we're a really big vaccinator these days. We've given well over 30,000 COVID shots since the start of the pandemic, and that's actually a part of our business that is helping us stay open right now. If COVID had not happened, and I hate to say this, we probably wouldn't be here because while, as I'll explain, we are underpaid or not paid when we fill prescriptions, we don't get paid enough when we vaccinate, not as much as medical providers, but we do get paid. And so that is part of why our door is still open. My last bullet there is pointing out the fact that we would love to keep growing. We would love to keep adding more staff. We would love to keep adding more services to our roster to provide to patients as is appropriate for our scope of practice, obviously. But the big if there is if we're able to stay open. And again, we've already kind of crazily, luckily gotten out of the pandemic and survived it because of it in a really twisted, awful way. And we are still very much in a very difficult financial situation. In short, we lose money filling prescriptions, and it's almost guaranteed if it's an independent pharmacy and they're accepting insurance and they're operating in the United States, they're losing money filling prescriptions too. And so we're going to talk about why that is. The other thing I wanted to note is that we are actually a pharmacy that is not currently accepting new patients, which is probably something that you've never heard of, or if you have, it's very rare. You know, it's something that we commonly see in the medical world with, for example, a specialist neurologist, right? They stop taking on more patients when they hit their bandwidth for providing safe and efficient care. And in November of 22, so a little over a year ago, we got to that place too. Acutely, it was mainly because a Walgreens down the street from us is in such a bad place. It was bad then, it's even worse now, that all of their patients were coming to transfer to us. We were having a stack of like 30 a day. We just got to a point where we couldn't do it anymore, or we were going to start making mistakes, and that's never okay. But additionally, you know, us not accepting new patients because we're getting such an influx from other pharmacies where people aren't getting adequate care is really a reflection of widespread erosion of quality pharmacy care, even in middle class, well resourced, affluent neighborhoods like Matt Groveland, where we live and practice. So a tiny bit about me. I am originally a sociologist by training, and I did graduate as a pre-med student with the intention of probably becoming an OBGYN. I love birth, I love sexual and reproductive health. But after a few years traveling the world and thinking long and hard about it, I decided that I wanted to be a midwife. And so I got my MSN from Columbia in New York City in 2021 and immediately moved into their DNP program in nurse midwifery. I have had to take a step back from that because of my own long COVID journey, which is still ongoing. So that is now a dream in progress, like I said earlier, but something I think I still want to do in the future. And I am really grateful for having landed where I did. It was not only a soft place for me to land working at the pharmacy for my family in the neighborhood where I grew up, but I didn't even understand fully how this issue was manifesting in our own pharmacy and across our nation. And I'm now very passionate about it. And I'm really excited that every day I'm getting to go to work and hopefully do something positive about it. I don't want to live in a country in a few years where independent pharmacies like us just aren't there. It will be dangerous, it will be unsafe, it will be all sorts of really bad things. So I am grateful that I get the opportunity every day to do what I can to make sure that that doesn't happen. As I said earlier, I wear a lot of hats at the pharmacy. I do nursey things like vaccinating and blood pressure checks. I'm also our mail order coordinator, which is kind of a made up role that I'll talk about later. And it's directly related to this issue that I'm going to be discussing, and unrelated, but I'm also our creative director because I like graphic design. And then one last thing I wanted to say is this picture up in the corner is of me sitting at our old fashioned soda fountain as a little kid. I really did grow up in this pharmacy from the days probably I was born up until now as an almost 30-year-old. And it's been an amazing journey, and I'm incredibly grateful. But I wanted to point out that this is an issue that, despite the fact that I've grown up in this pharmacy and I speak this language, I am still learning about every single day. I learned new stuff today at work. So it's complicated. If you're finding it complicated, that's normal. It's designed to be that so that the problem can't be fixed by the powers that be. And so, you know, as we're going through this presentation, if you have questions, write them down. And if we don't get time, I can address them via email or phone at a later date. So, but let's get started because there's a lot to talk about. So we, not so affectionately, call the PBM industry and our family and our business the PB Mafia because They really are a modern day mafia of sorts. And unfortunately, they have a lot to do with care and how that's provided and accessed in our country. So, but firstly, let's talk about what is a pharmacy benefit manager. Like Kathy said, this is something that she had never heard about. I wouldn't be surprised if none of you of the room have heard about them. They're not a commonly well-known entity, but they're really important. So a pharmacy benefit manager, or we'll just call them now a PBM, by definition, they are companies that manage prescription drug benefits on behalf of health insurers, Medicare Part D drug plans, large employers, and other payers. In short, they are the middlemen that exist between pharmacy providers like us at St. Paul Corner Drug and payers, right? Includes federal and state governments, Medicare, Medicaid, large employers like Boeing and 3M that handle their insurance in-house, private health insurance companies like Health Partners, et cetera. They are responsible for handling a number of different things within the pharmaceutical industry. When they were created in the 80s, I believe, they really were just meant to help streamline this processing of prescription claims and keeping costs low as the pharmacy industry grew, right? As research and development expanded, as more manufacturers were created, as more drugs were created and used by patients, things were getting more complicated. And so the idea was that outsourcing the processing of prescription claims from insurers, moving those out of house per se, to this middleman would help be kind of like relieve some administrative burden, help control costs, that sort of thing. So that's like the main thing that they were designed to do, is kind of be the Visa or the MasterCard of the pharmacy industry when we're talking about processing and billing prescription claims. They're also notably now responsible for creating the formulary or the list of covered drugs for a payer like an insurance company. Right? So something that decides, oh, this drug is covered or not covered by my insurance, or if I need to take it, is a prior authorization required if it's not covered? Um, and that means that they have a lot of influence over the drugs that individuals use and determining out-of-pocket costs for patients. Notably, they also negotiate rebates with drug manufacturers. And while in theory, this was designed again to be a cost control measure, right, to keep costs down, because if a manufacturer is the only one that produces, for example, a still brand name drug or a brand name drug that's still on patent and hasn't gone generic, um, they get to essentially kind of set the price at whatever they want. But unfortunately, that hasn't controlled costs. Instead, these entities often keep these rebates as profit, which we'll talk a little more about later. They also create pharmacy networks, review drug utilization, and they also manage mail order and specialty pharmacies, to my dismay, because I have to interact with them pretty much every day at the pharmacy, and it is not very much fun. So on the right, on the red and white part of the screen, you'll see the names of kind of the main PBMs that John and I interact with on a daily basis. It's partly shaped by the insurance plans that our patients have living in the state of Minnesota, but CVS Caremark, Express Scripts, and Optum Rx, so three of those six are considered the big three. They are the biggest PBMs in the country, and together they account for like over 80% of the PBM market. So they really are nearing kind of a monopoly of sorts, and we know that they're all in bed with one another in some way, shape, or form. And so that's incredibly problematic when you're thinking about anti-competitive practices. And then additional to them, if you've heard of Humana or Med Impact or Prime Therapeutics, those are also commonly ones that we are billing prescription claims to. In parentheses, you'll see I've included information about like different legal affiliations that they have, because that is a big part of this problem, is that, like I said, everyone's in bed with everybody else and there's zero transparency about it. It gives them a lot of power to do things like price fixing, which is just extorting from the industry and patients. So, for example, CVS Caremark, even if you haven't heard of them, you've probably heard of CVS pharmacies. Those two together make CVS Health, this bigger kind of umbrella company, which also owns Aetna, right? A huge health company. Express Scripts is owned by Cigna, another huge health company. Med Impact and Prime Therapeutics are both somehow affiliated. We're not really sure how, with Blue Cross Blue Shield plans, and in the case of Med Impact, Health Partners as well. And then OptumRx, the third of the big three PBMs, is owned by United Health Group, or more traditionally called United Healthcare, or UHC. And so these are the entities that we're talking about today. These are the bad guys. And the term that I'll use throughout this presentation that we're really talking about today, PBM abuse, that's the umbrella term that we use to refer to the ways in which these entities and the rest of the PBM industry abuse the American healthcare system in both ethically questionable and outright illegal ways. And of note, we cannot avoid working with them. We need to have a contract with the PBM in order to be in network with the insurance company that they're acting on behalf of, and to bill that plan. They are at this point like a built-in inherent part of our system. And so they are, as I said, unavoidable. So this next slide, I won't go into too much detail, but I just want to use these numbers to really point out how lucrative this PB mafia is. It's not just a little bit, it is hundreds of billions of dollars a year. This is the annual revenue from financial reports, with the exception of two that I could only find from third-party sources in 2022. I'm very interested to see what these numbers will look like for 2023 once I can find them. But as you can imagine, this level of wealth gives them almost unmeasurable amounts of control and ability to extort from our healthcare system wherever they possibly can. And if you think about it, like I was saying, these entities were really meant to be, right, a middleman that was handling electronic processing of prescription claims, right? So a couple cents on the dollar, process a claim, a couple cents on the dollar, process a claim. That's what they were designed to do. And yet they're netting hundreds of billions of dollars in revenue every year. The math doesn't add up. And they're causing lots of other issues related to it too. And so, like I was saying, they were created in the 80s, I believe, but already pretty soon after that, by 1998, PBMs were under investigation by the Federal Justice Department and US attorneys, and their effectiveness in reducing prescription costs, right? One of their main purposes, and saving patients money, was already being questioned. So they've been kind of, under the microscope for a while now, but really the last few years is the first time that we're seeing any kind of real movement on regulating them and holding them accountable for past abusive behavior. And as you all probably know, as nurses, the reality of the situation these days is that drug costs are out of control, medication and pharmacy care accessibility is decreasing. And so if these entities making this much profit were actually benefiting the system in the way that they're supposed to, we would see it. But we're not. We're actually seeing a system that is crumbling, more and more day by day. So I want to talk a little bit about how we work with PBMs, because that's essential to this talk. So, and it really gets down to how we are paid, right? Because like I said, we are required to work with this entities in order to bill prescriptions to insurance. So in the middle here, we have the PBM. On the left, we have the pharmacy provider. So for example, us at St. Paul Corner Drug. And on the right, we'll call them the payer. So whoever's covering the cost of this patient's care. That could be the government, state or federal, a private insurance company, or like I was talking about, a large employer that handles insurance in-house. So the payer has a relationship with the PBM. They pay them some kind of administrative fee to work with them in order to get these services down here of claims processing, formulary creation, et cetera. And then in working with them, they're also supposed to, when we bill a prescription to a patient's insurance plan, pass on the cost of the coverage of that care, that prescription for the patient. The PBM processes the claim. They're then supposed to pass those monies on to us in the form of a dispensing fee that accurately reflects our operating costs, our supplies, our people, our time, all that stuff, and the cost of the drug, right? How much does it cost to get that lisinopril or that Eliquis into our pharmacy in order to dispense it to the patient? And this amount of money, right, is supposed to be enough for us to make some kind of profit, because we are a for-profit business. We also, in turn, do pay some kind of small administrative fee to PBM. My dad has admitted we don't really know exactly how that works or what it is. But right, which makes sense, right? They are providing a service to us, even though we don't get to choose. So this is how pharmacies like us are paid, and PBMs are at the very center of it, literally. I wanted to show this graph because it's one directly from our government, from the Congressional Budget Office in 2007 when Medicare Part D was born, but it's missing some stuff. The PBM's in the middle, and these arrows here are supposed to be showing the flow of funds and services. And I think it's really uh, just kind of crappy or misleading that these arrows only lead in one direction. It makes it look like the pharmacy benefit manager is providing everything to the pharmacy. In reality, these really kind of go in the opposite direction. Um, the only service they are providing to us is allowing us to bill a claim. They're taking a heck of a lot in return. The flow of funds is definitely in the opposite direction. The first thing I wanted to point out is that over 50% of the claims that we process through an patient's insurance plan, and therefore a PBM, uh, give us back or reimburse us back a $0 dispensing fee, when it really should be at a minimum across Minnesota based on data collection 12. More at our pharmacy, John has said probably somewhere around like between 15 and 17 is a realistic cost of what it costs for us to fill a prescription. So we usually don't get paid to do our work, which is a super bummer. And of note, in the late 80s, this fee was actually $7 to $10 every time we filled a prescription. So we're actually going backwards, not forwards with time. Secondly, I wanted to point out that the small administrative fee, whatever that is, that we pay to the PBM for processing this prescription claim, right? Because we usually get paid nothing, we're actually paying the PBM more than they're paying us to do our job, right? Um, so again, just really problematic. And then the third thing that's missing from this graph is something called DIR fees. More commonly, they're called clawbacks, if you've ever heard of them. And we call them that because they really are this clawing back of monies that PBMs have already paid us. So up until 1/1 of 24, the turn of this year, this is how DIR fees work. I just wanted to explain them briefly. So step one, we buy a drug like lisinopril from a wholesaler for X amount of money. When we fill it for the patient, we submit an insurance claim that includes the cost of that drug plus, right, whatever it costs for us to fill that prescription. Step two, the PBM then adjudicates the claim and is supposed to remit payment back to us in the form of a reimbursement, right, for that, for example, $100 that we asked for. And in this situation, this math would leave us with a gross profit of $15. Now, there are problems with these two parts of the equation, 2 and 3. With number 2, we, as a standard, have to inflate the amount that we submit in the form of a claim to a PBM just in order to make enough to get by. And by getting by, I mean like losing less, but still losing money dispensing prescriptions overall. So it's a really sad day when like that has to become the standard, when you have to ask for more than what you need just to get by. And then the problem with step 3 in here is that, like I was saying, the PBM rarely pays us what we submitted. And in certain cases, specifically Medicare claims, which is where DIR fees come into play, they are a thing because of a loophole in Medicare law that PBMs have found a way to take advantage of. They actually, months later, up until 1/1/24, 3 times a year, every trimester, would come back and claw back a DIR fee. We don't even know how that works, what percentage it was, how they play out the math. There's no transparency on that. But they'd essentially be coming back to us and serving us this massive tens of thousands of dollars bill saying, okay, well, you owe us this money back for literally no reason other than we can collect it. And so in this math on this page, right, in this example, we're cutting the pharmacy's gross profits by 50%, meaning we're getting like $7. That often doesn't happen. On Medicare claims, we get hit hard, and it is a financially really disastrous situation. And related to this situation is what I do as our mail order coordinator. So last year, we were brainstorming ways as a team to keep our pharmacy open while we're weathering this kind of worsening storm. And one of the things that we were thinking about, my dad was like, we have got to get prescriptions that we actively lose money on off of our books. That is really hurting us. And so I was like, okay, I'm here. I've got time. I think I can do this. And so my pet project became coming up with a framework for talking to every single patient that we serve at our pharmacy who has one or more prescriptions where we are actively losing money filling the prescription. In other words, meaning that we are not even getting reimbursed enough to cover the raw cost of the drug or how much money it takes to get that medicine in our store to dispense it to them. So I created a framework for talking to those patients. I did research on all the different options of different pharmacies and different pharmacy choices that they'd be able to transfer their prescription to in order for them to continue getting most of their pharmacy care at our pharmacy, but not having us paying to be doing our jobs. And then kind of an offshoot of that, I necessarily learned about mail order pharmacies, how they work, how to use them, the ins and outs, tips and tricks. So I've spent the last year spending a good portion of my time at the pharmacy independently managing and training other people to manage the mail order needs of certain patients of ours who, for example, were taking an Eliquis prescription or filling their Lantus insulin at our pharmacy and that we were paying to fill. And so with the patient's consent and their help, we have moved just those prescriptions to, in the case of patients who can't do this work themselves, mainly Medicare patients, the elderly, people who face a cognitive or physical disability that prevents them from doing this on their own. I essentially am the middlewoman between them and their mail order pharmacy. And so I spend my time helping them get that one or couple of medications filled via that pharmacy, just kind of acting like a healthcare coordinator so that our pharmacy, St. Paul Corner Drug, doesn't have to pay to fill it, which is a really twisted way to spend my valuable time that I could otherwise be spending with patients doing lots of different other stuff. So DIR fees are a big reason of why I am the so-called mail order coordinator at our pharmacy and kind of headlining that pet project of moving prescriptions out of our pharmacy that we lose money filling. And it's technically a legal gray area for us based on the, as you can imagine, abusive one-sided contracts we're forced into with PBMs in order to do our work. But we are in full on, I'm trying to think of a non-bad word to use here. We're at a point where we don't have a choice. That's really where we're at. And so we're asking patients to do that for us where they're willing and able. This number here on your screen, I wanted to put this in here today. This is the amount of money that our pharmacy has already paid out on DIR fees. And remember that that's just related to Medicare prescription claims in 2023. As you can imagine, for a little pharmacy like us, that is a lot of money. Well enough to cover the salary and benefits for 2 full-time pharmacists that we could otherwise be employing at our pharmacy or using elsewhere to provide great care for our patients. But instead, we're paying it to PBMs retroactively until 1/1/24. Now, since 1/1/24, we see it actively in the claim. So a bit of an improvement in the sense that we can see how we're getting ripped off, but we still can't do anything about it. And so it's mind blowing. It's like Kathy, I think, said earlier, outrageous, absurd, if those are even words that do it justice. And so moving to this next screen, this is kind of an adaptation of that graph that I showed you earlier about how we get paid. Now I want to focus on how the middleman, the PBM, makes money. So they're still here in the middle. This big fat gorged arrow is showing all that money that they're making, those hundreds of billions of dollars a year. And the red arrows are some of the ways in which they're doing that. The rebates that they're negotiating with drug manufacturers over here, those monies that they're supposed to be putting back into our health system through payers, through other means, in order to benefit everyone that's cared for in our system, they're simply keeping them as profits. Over here, that dispensing fee and cost of the drug that they're supposed to be, passing along from the payer to us, like I've been saying for the last few minutes, it's just not happening. Our dispensing fee is usually 0 or cents on the dollar. And there are some prescriptions, many actually, in which we're not even making enough to cover the raw cost of the drug. And like I said, those are prescriptions that we are doing everything we can to actively move out of our pharmacy, despite the fact that it's a bit of a sticky legal situation for us. We're technically supposed to fill every prescription that walks through our door without discretion, but that's not realistic if we want to stay open and caring for our patients. And then we've got this other arrow over here, like I was talking about, the DIR fees or clawbacks on Medicare claims, that is further engorging this arrow. And a great example of this that I wanted to point out, there was a bill that was being debated in the Minnesota legislature that last year that unfortunately didn't pass at the very last moment, 30 minutes before the omnibus bill was voted on. But currently, we have all kinds of data to show that managed care organizations that are caring for patients in the Medicaid system in our state, we have data to show that so much money and resources are being funneled into PBMs instead of funneled into covering the cost of care for these patients. And that bill was going to take PBMs out of the equation and go back, establish a new system, which is really an old system that would go back to a traditional dispensing fee model, right? Where we'd get a dispensing fee and the cost of the drug. And that would be a set thing. We'd get it for every prescription, easy peasy lemon squeezy, simple math. It's how we used to get paid. It's how we want to be paid if we had a choice. So we were really hoping we could get PBMs out of the equation, at least in Medicaid in Minnesota, and that didn't happen last year. It's something that we're really hoping can happen this year. On this next slide, so this is just a funny little kind of or irreverent cartoon from PUT, this organization that we love. They're all about legislative advocacy and advocacy on PBM abuse specifically. But all of these different colored boxes are examples of, do you do this really horrible thing? And if the answer is yes, then you're a PBM and you get a government contract. And that's the really another unfortunate thing about this problem is our government, whether they know it or not, is entirely complicit in PBMs growing out of control and really running the show. They have been allowed to participate in anti-competitive practices and participate in vertical integration, buying up healthcare systems, buying up insurance companies. So it's all one bucket of money. They haven't been held accountable for breaking the law. And when they do, right, sure, it's a couple $1,000,000 in a lawsuit, but like I say down here, they have a special budget specifically for that. So I won't go too deep into this because we're already a little short on time. I have more I want to talk about, but in these black boxes are all different things that are kind of the manifestation of saying yes to this not so great question on this funny little graph. PBM's patient steer, meaning they force patients to go to pharmacies that they own or operate, which is outright illegal, but they do it all the time anyway. There's a severe lack, in some cases, complete lack of transparency in what they do and how they do it. Like I was saying, vertical integration that leads to anti-competition, and simply running, in my opinion, incredibly poor quality pharmacies, mail order pharmacies and specialty pharmacies, which they say they think is the future of pharmacy in this country. I can tell you, they're not, and we don't want them to be. I spend all day, every day working with them, and it is a constant uphill battle. And I'm a registered nurse, right? Highly educated, young, tech savvy. I can't imagine that my 90-plus-year-old patients would be able to manage their mail order needs on their own. And that's just something that shouldn't be. You should be able to deal with your pharmacy on your own, or maybe with a little bit of help. Like we were talking about way early in this presentation, they force patients to take expensive brand name drugs when a generic alternative exists because, right, they're choosing to include that drug on a payer's formulary because they get a better rebate from the manufacturer. So it's not because this drug versus the generic that the brand is better, right? That's not how brands and generics works. They're therapeutically equivalent. For all intents and purposes. It really is a money-making scheme, forcing patients in a lot of situations to take these expensive brand name drugs when a generic alternative exists and would be far more affordable and just as effective. And then one last thing I wanted to bring up, this is something that we've just discovered this year. So in the last 3 weeks since the turn of the year, we are actually noticing on certain commercial claims. So this is a prescription ticket from our pharmacy. I've obviously de-identified them, but as you can see, this box here shows the insurance company. So this would be, both of these are health partners. And this is where you would usually be showing our reimbursement, right? So if it's zero, it means that the insurance company, it was billed correct, or it was billed successfully, but they're not covering anything on it yet, meaning the patient hasn't met their deductible, right? Most people have a deductible on their plan that they have to meet before insurance coverage kicks in on their prescriptions. But instead of it being zero or a positive number, what they would be reimbursing us for filling that prescription, there's a negative number there, which is it just absolutely backwards, does not make sense. This is, we think, like partly a consequence of those DIR fees or clawbacks that I was talking about, moving into an in the moment charge to us, the pharmacy, instead of a retroactive thing. Like I said, that change happened at the turn of this year. But John is also investigating this further and has found out, in short, that some really scummy things are happening behind the scenes. In short, some form of price fixing, which is just fraudulent, right? So these PBMs are working with each other, working with insurance plans, working with, now we know, entities like GoodRx in order to quote unquote get discounts for patients, but then they're taking money from the pharmacy provider while they're at it, and probably also upcharging the patient too, if we're being honest. So all of these things together, all of these different things that I'm talking about, all fit underneath that umbrella of that term I used earlier, PBM abuse. And they are the primary reason why independent pharmacies like us are dying. But they're also related to a lot of other issues that are going on in our health system right now. So let's move on to talking about more big picture items. And what I wanted to talk to you about first was the idea of a pharmacy desert. As at least some of you have probably heard, right? We often use the term desert in this way when we're talking about something like a food desert, right? Meaning a lack of an essential service or a necessity for life in a community, like a neighborhood, for example, or a county. So these are all just headlines of recent articles about pharmacies closing. But we really are at a point in time where this problem of pharmacy deserts is real and getting worse by the day. Um, Oops, sorry about that. So this is kind of the reality of this situation. In our state over the last decade, I'm sad to say, we have lost more independent pharmacies than any other US state. And that includes 24 last year alone. And if you think about it, in 2017, there were specifically independent pharmacies like us, 23 in Hennepin County and 21 in Ramsey. We live in a big metropolitan area. So if we were in the low 20s in 2017 and this problem is getting worse and worse every year, think about how many indie pharmacies exist in the Twin Cities metro area right now. We know that we're one of only a handful, and we are all losing money dispensing prescriptions because we're accepting insurance. Like I said earlier, it's a guaranteed, because it's how our system works. It has to do with how we get paid. And of note, if any of you watched the short video that Kathy sent a link of John testifying to the Minnesota House last year before the presentation, he brought up that our newest pharmacy desert, or one of the newest, is our in North Minneapolis, right? So nearby, we have this community that not only has lost its last grocery store last year, but also has lost its last pharmacy, chain or independent. And that's a scary reality, and it's going to become more common with time if this issue isn't addressed, and soon, and in a large scale way. And so then kind of moving to broadly across our nation, talking about like, why is a pharmacy desert significant, right? Food desert, right? Easy to think. We need food to survive. But I don't think culturally a lot of us really appreciate the essential nature of pharmacies. Pharmacies, especially those like us at St. Paul Corner Drug, and in particular independent pharmacies, right, being run by families or groups of pharmacists that are really in this work for the right reasons because they care about their patients and they're willing to go the extra mile for them. We do so much more than fill prescriptions. We offer free blood pressure checks, we vaccinate. We have the ability in some cases to rapid test for infectious diseases like COVID and flu. We're hoping in the future at our pharmacy, we might be able to provide like vaccinating injections for certain mental health conditions and HIV prophylaxis. Pharmacies sell life-saving over-the-counter medicines such as emergency contraception and naloxone recently. We offer MTM or medication therapy management services. We assist in the management of chronic conditions. We do all sorts of stuff outside of just filling prescriptions, but I don't think a lot of people think about that until we're gone. And this is especially essential in rural areas or low income areas where pharmacies and pharmacists are often the most accessible healthcare provider for those kinds of communities, right? That are already facing disparities in health access. In our family, we often use the analogy of the goalie because I was an ice hockey goalie up until college. And that's really what, in my mind, like pharmacies are. That's the analogy that comes to my brain. When we're gone, there's no one else left. We are often the most accessible person or the easiest provider for a patient to get a hold of, especially in an area where they're already struggling to access care. And we often see our patients more often than most care providers or healthcare workers. If you fill your prescription 4 times a year, we see you 4 times a year. If you fill it every month, we see you every month. And so we're incredibly important, but I don't think valued as such. And again, when we're gone, there's nobody left. We're the end of the road. We're the goaltender, and all that's left behind us is the net. Um, and a little statistic for you that you can take away from today. So currently, based on data from the Pharmacy Access Initiative, which is this new project out of University of Southern California in conjunction with the National Community Pharmacists Association or NCPA, one of kind of our representatives on a large scale. It is estimated that about 1 in 4 neighborhoods, so 25% of Americans broadly across the US, could be considered a pharmacy desert. And that is like a definition that's been agreed upon is living in a rural area where you'd have to drive more than 5 miles to reach a pharmacy, or an urban area where you'd have to either take public transit more than a half mile, or if you have access to a car, drive more than a mile. That's what we consider a pharmacy desert. And 1 in 4 of us living in this country are living in one right now. And again, this problem is actively getting worse by the day and going to continue to do so if we don't do something about it. I put this quote in here, 1, because I love Hubert Humphrey, 2, because most people don't know that he was a pharmacist before he became Vice President of the United States. But also it's because it's really about the fact that, right, the benefit of living in a modern society in this national community is that we are supposed to have governments that help level the playing field and perpetuate the idea of equity, right? The moral test of a government, as Hubert Humphrey said, is how our government treats those who are most vulnerable, essentially. And like I was saying, things like pharmacy deserts, lack of access to essential pharmacy care, it of course, unsurprisingly, disproportionately affects like most other social deserts, our most vulnerable community members, right? Everybody listed in this quote, including BIPOC and queer individuals, the disabled, the young, the elderly, right? And so this is really an issue about access to care at its heart, and helping create a health system that actually does what it's supposed to do. In a country that certainly has the resources for it and the necessity for it. And a lot of people say, well, oh, well, I know you little guys are dying, but that's just kind of the nature of, competition over time. We do live in a capitalist society. If you can't swing it, you won't stay open. But we will tell you, anybody working at a pharmacy like us will tell you very soon, there is going to be nowhere else to go. We have dozens of patients every week reach out to us about transferring because they are getting horrible pharmacy care elsewhere. And that reality is only going to worsen with time. National chains, so for example, the CVS, the Walgreens, they're closing these days at increased rates due to a number of different factors: retail crime, growing competition, staffing shortages, minimal store investment. So just not giving the people who work at those stores the resources to do what they need to provide safe and efficient pharmacy care. And I can tell you in short, mail order pharmacies are not the future. They're mostly owned and operated by these scummy entities. They are cumbersome, they are confusing, they don't communicate clearly or at all. And overall, they're known for providing poor or even unsafe quality pharmacy care. I won't go into detail on that. I could talk to you about it for hours. If you want to know more, send me an email and I'll be happy to tell you some stories that I've gleaned over the last year. But of note, they're also not an option for filling certain medications, like an antibiotic that a patient needs for a UTI and that they need to start right now. They're not going to get that from a mail order pharmacy. They need to get it from a community based pharmacy. So when there's no community pharmacy left, we've got a problem. Um, and a great quote that I found from one of the uh, resources that I mentioned on my resources or references list regarding chain pharmacies is that the economics of running those stores have just unraveled and they're not as profitable as they once were. Retailers are looking to offload them. And that really is the case. Have you ever wondered or thought about the fact that, these chain pharmacies will come into your neighborhood for just long enough to drive out independent pharmacies like us? We die because of this issue of PBM abuse that I'm talking about. And then they leave a year, two, maybe even less time later, because it's not that they're losing money. They're just not making enough as much as they can, either moving to a different area and opening up a new store or participating in other ventures related to pharmacy. So this is a cartoon that I love from Putt. It's just a good summary of what we've been talking about probably over the last like 30-ish minutes. So all of us are sitting here in some way, shape, or form. We're playing literally a game, right? This really does feel like a game most days in our work at the casino of pharmacy benefit management. The PBM is sitting here and they're raking in all of the profits. And you can specifically see on these chips all the different things we've been talking about, the ways that they extort this system: DIR fees, patient steering, keeping rebates for profit from manufacturers. And again, some of these things are, like patient steering, outright illegal. They are not allowed and are breaking the law, and they still do it anyway. And so we are left struggling to afford and access and provide care while PBMs are making more money than they know what to do with. And that is exactly the way they want it. And they want it to stay that way. So in short, who is suffering in this system? And I like to think of it as the three Ps: the providers, the payers, and the patients. In providers' neck of the woods, they're facing, or maybe even you all in the room, if you're APRNs, increased difficulty prescribing certain medications, right? If they're not covered or they're not accessible to patients. You're facing an inability to afford to accept certain insurance plans if you run your own practice. This problem of not being, literally not being able to afford to work insurance is also happening in medicine in its own way. You're facing increased logistic hurdles, which means you're spending less time with your patients. And a lot of people are leaving practice straight up from burnout, right? Especially post-COVID, which is why we have such a issue with lack of access to providers these days. Payers in the middle mainly are overpaying for pharmacy services rendered, like I talked about with Minnesota Medicaid and MCOs. Us taxpayers are helping financially support the system to care for our most vulnerable neighbors, but the money we're spending isn't actually helping cover the cost of that care. It's going to pharmacy benefit managers in the case of prescriptions. And then patients especially are suffering. I hear stories every single day. They're overpaying for prescriptions. They're being forced to take more expensive medications when there's a more financially affordable option that would be just as effective. They're being forced to change pharmacies, sometimes even after decades working with the same pharmacy. They're facing increased difficulty accessing pharmacy care at all. And so just kind of a summary slide of really, really what's going wrong here and who it's affecting, which in short is everyone. And so briefly, I know I'm running a little short on time. I just want to quick talk about what the different things we'd love your help with after today's talk. So kind of the four main things. First and foremost, learn about this issue, ask us questions where you have them so that you're understanding, and please, please, please spread the word. I cannot tell you how rare it is that I find someone on the street or who walks into our pharmacy who knows what a PBM is or knows what they do. And I'm a nurse, and you guys are all nurses. And so we probably know a lot more healthcare providers than the average person on the street. And still, my friends who are physicians, my friends who are nurses and APRNs and PAs, none of them knew what a PBM was, not a single one, until I told them about it. And they are all unsurprisingly astonished. And when we as healthcare workers and our patients are not informed, we can't make informed decisions about their care. They can't make informed decisions about their own care. And they also can't advocate for themselves. And lack of awareness and understanding, even in the case of legislators. Kathy earlier was saying that, often the word PBM, if she hears it in a conversation, right, eyes just glaze over, right? Even the people who are representing us in our state legislature and our Congress don't truly understand this issue. I haven't met or seen a video or saw a talk or what have you, a single one that seems to really truly get this. So we really need to spread the word so that patients know that this is happening, and so that people can, for lack of a better word, get pissed about it and help us do something about it. Because if we don't know a problem exists, we certainly can't fix it. Contacting your legislators, which I won't beat a dead horse. I know everyone in this room participates in some kind of legislative advocacy. It's part of why you're here. But there are bills, and information can be found on our website. If we have time right before the end, I'll show you. But if not, stpaulcornerdrug.com/legislative-advocacy. I have a whole page that I update as regularly as I can, specifically about the bills that are being worked on the state and federal level regarding PBM abuse, reforming the PBM industry, regulating them, holding them accountable, all that good stuff. And we really need those bills to pass. Without legislative reform on this issue, independent pharmacies like us will die. We can do everything else in the world to keep our doors open, but without legislative reform, we're not going to find a lasting solution to this problem. Another thing that you can do in your own personal life and encourage others to do is patronize indie pharmacies like us. Even if you don't fill your prescriptions with us, we're a great place to get your over-the-counter medicines and other health supplies that you might need. Like I said, it is almost a guarantee that any pharmacy like us that is using insurance to fill prescriptions in the United States is overall in the red or losing money dispensing prescriptions, which is, right, our primary purpose. And so if you can help put money in our pocket in other ways and financially support us in other ways, we greatly appreciate it. And it is something that helps us keep our doors open and our lights on, hopefully long enough to weather this storm and wait for legislative reform to take hold. And then the last thing I wanted to bring up is about choosing insurance or participating in self-pay pharmacy. I know that a lot of us, especially those of us getting our insurance through work or a retirement benefit, for example, don't have a lot of choice, but you can ask questions. For example, does your insurance provide an administrative fee there, and i.e. paying a pharmacy to provide you a prescription? Or are they a plan that just doesn't do that? OptumRx, their plans usually don't do that. And our patients don't know until we tell them. And even if you can't choose your insurance, right, you don't really have a choice, but you find out something unjust like that is happening and that your insurance plan is participating in this problem or contributing to it, follow up on it. File a complaint with Minnesota Department of Commerce. Do something about it. Talk about it. Call them up and say, why aren't you paying my pharmacy? They can't stay open if you don't. And while that only goes so far, we do need to spread the word on this issue, and things like filing complaints with Minnesota Department of Commerce, especially when your patient rights are violated. For example, when you are steered by your PBM or insurance company to another pharmacy, which, like I was saying, is illegal. Those things all help shed light on this problem. Oh, and related to that also, I don't know that there are any other pharmacies like us doing this or growing what we call our self-pay program or filling prescriptions without insurance and instead out of pocket. But if you find a pharmacy that you can be a patient at that's doing that, I would strongly recommend that you consider filling at least some or all of your prescriptions out of pocket if you're able. And you'd be surprised how often that actually is cheaper than using insurance, because these days, insurance doesn't mean your care will be cheaper or more accessible. At the end of the day, insurance in our country is a for-profit industry. And these days, they really have figured out a way to make it all about making money. So when we take them out of the equation, we're ensuring that pharmacies like us are making money doing our job filling prescriptions. So if you get the opportunity, either at our pharmacy or elsewhere, to participate in a program like that, look into it. And then we'll just skip that slide. So lastly, I just wanted to end on this. I thought that this was another great comic from PUT, that organization I was talking about that we love. This is kind of our reality these days at St. Paul Corner Drug and other independent pharmacies. We're here working in the back and we are sweating. We are scared. We are anxious. We are facing the emotional, physical, spiritual, financial, what have you, burden of working in an independent pharmacy in this unjust and abusive system. We know that the PBM is here with his cannonballs doing all these different things to take advantage of us and take advantage of you. And up here, the patients are smiling. They mostly don't know that there's any problem happening. And it's the how transparent we are being with our patients, I think is a very newfound thing. We don't have a lot of patients at our pharmacy anymore that don't know that these issues are going on, but the amount of time and energy that we're spending telling them about it is significant. And there are a lot of pharmacies that haven't even started that process yet, and it may be the death of them. And so with that, I've got a page here if you want to learn more. I hope that you do after this talk. Have some resources. Everything that's underlined is a clickable link, or should be, but if you have any issues, you can let me know. I can certainly answer any questions you have about these resources if you take a look at them in the PDF of the slide deck Kathy said she would post. Here are the references that I used in today's presentation. And then here is my email, which you can write down or take from the slides after the fact, again, after Kathy has uploaded them. Please, please, please reach out to me if you have a question. If you want to know more specifically about what I'm doing with mail order coordination at our pharmacy, or even if you have a patient who needs to know how to use a mail order pharmacy, I have materials that I can share with you, things that I've learned the hard way so that you and your patients don't have to. And also, if you happen to know a group of people who would want a presentation like this done for them as well, who would be interested in learning more about PBM abuse, I'm your gal. I am more than happy to work with you and make that happen in whatever capacity that we can. So in short, well, not in short, I know that that was longer than I meant to go. I'm so sorry, Kathy. Thank you so much for listening and for your time. And I'm available. I don't know if John is, to stay on a little bit longer and answer questions. But if not, like I said, you're more than happy to email me and we can always set up a phone call if that would be easier too. So I'm going to stop sharing my screen now. And it looks like we have a couple different questions in the chat, but maybe let's take hands raised first. So Cami, are you raising your hand with a question?
Yeah, and probably more of a comment. So I'm part of a leadership, and we look at our health insurances every year, and we're self-insured. The program that is always coming at us is kind of the type of pharmacy program that really is intended to save us money in a self-insured plan, which is going to fall right into that. And I'm wondering, at what point, because as an employer, we're looking at the bottom line, right?
Yeah.
We're looking at what we have to pay for health insurance. And so you don't always look at the further end, because you're looking at, okay, what are we going to do? And I'm in long-term care, so our rates are what they are. And it just becomes a difficult, it's an interesting problem, right? Because
Yeah.
in one hand, we have to be able to supply health insurance for our employees. Our brokers, because we're self-insured, are going out to try to get us the best deal. And always the pharmacy plans are part of it.
Yeah.
So,
and that's, oh, go ahead. I don't mean to interrupt. Sorry.
No, I just wonder, like that seems to be an opportunity or something that really how does that happen to be where it's ends up the outcome as it ends up?
Yeah.
And how do we address that?
Yeah, and I think that's one of the harder things, and that's why, I put it on the slide, but tried to add that caveat is that I know that a lot of us actually don't have a ton of choice when it comes to insurance, which is unfortunate. And patients ask us all of the time when we tell them, your insurance is one of the especially crappy ones to work with for us. They say, what's a better one? And our answer is there isn't. There isn't a good option. And so it is sticky. And I'm still learning a lot about that. So, I don't think that I have a ton of experience to lend to that. I don't know, Dad, if you want to speak on that. Um,
Yeah,
I
I
think it's
think,
tough.
Cami,
I
is
think it's
what you're
really tough.
saying, is what you're saying, Cami, that you choose the health plan and there's a pharmacy benefit attached to it, and it just comes with the plan, and there is no changing that or making adjustments to it or deciding if something's better or worse.
Well, in our self-insured evaluation of our programs, our broker goes out and looks at it and then says, well, this is the health plan, but we can join this other pharmacy plan that's going to save you more money because you're self-insured.
And are those reasonable choices, or is it like a difference between being a CVS Caremark plan, an Express Scripts plan, or an Optum plan?
Yeah, it's like
Those are the big three.
right. It's like
Oh.
a Scripts plan, Express Scripts. It's one of those types of plans, but our brokers have enough information from those programs to show
Right.
us how much we can actually save. Being in a self-insured plan, you're looking at what your employees are really spending on drugs and what they are. So your broker goes out and gets that from like the script plans. I think I want to say, I think it was a script, and then they can say, well, we can save you this amount of money in that, and that's what our broker brings back to us.
Yeah. Right. And so the interesting thing would be is if you had self-insured data, so you know exactly what you're paying for stuff, and bring that to a pharmacist and say, are these prices reasonable? Because savings is not hard numbers. They say if you do this, then that. But if the savings, if what they claim to be savings are fictitious, then are they really savings? But if you took those costs and took them to a pharmacist and said, what do these drugs cost? And I can guarantee you that I can look at it and go, you're being way overcharged there. You're being way overcharged there. And they tell you that they're giving you the best price. I mean, this is where people that are making benefit choices that don't understand the movement of prescription drugs and what drugs actually cost are getting taken. And it's all by design. It's by design.
Yeah.
And
It does make you wonder if this kind of information being helpful to large employers that are self-insured would be useful,
And I'll just weigh in here, John. So you and I used to work together when I was the case manager at Wellington, and my mom's a pharmacist, my son's a pharmacist. So we talk so much about PBMs.
Right.
And I work.
And the
Go ahead.
Yep.
I was just gonna say, so my job right now is working with employers, and in that role, I work with PBMs and I work with, carriers like Blue Cross of Minnesota. And I have some employers who are savvy enough to recognize the smoke and mirrors that's happening with the PBMs and have moved towards PBMs like Navitus, who remove all rebates from their plan. And so it's very transparent. What are we paying for? I'll make this up, lisinopril. But they are, of my several employers that I work with, the rare commodity. So I do think legislation is going to be what it's going to take to get this over the next step.
Yeah,
Dad, we're kind of losing you.
the problem I see with big employers that are self-insured is that they have a budget. And as long as they hit their budget, they don't care. What I was saying, and I don't know if you heard this or not, but big employers have a budget for healthcare. And as long as they have their budget, they hit their budget number, they're okay. They don't ask any more questions, whether they're getting taken or not. And they just assume that from year to year, the price is going to go up. And so if it only went up so much, they're all good. When in fact, they could probably be saving a ton of money by making different decisions.
Yeah, and I think we just rely on our brokers a lot for that stuff, right? Which is a good point.
Yeah. And we really saw that with Medicare changed a lot at our pharmacy this year. It's been or in 2023, technically, it's been a very sticky thing over the last few months. And we, a big thing is that we are not in network with Express Scripts plans for Medicare this year, which is a lot of patients, because Blue Cross Blue Shield is their PBM is Express Scripts for Medicare. And Blue Cross Blue Shield, right, being a Minnesota company, is a very commonly chosen health insurance plan. It for a long time, it was considered gold standard of insurance in Minnesota. That's definitely not the case anymore. We have the data at our pharmacy to show that. But it's a lot of my patients, even like my mail order patients, for example, who I was like, hey, we need to talk about insurance for next year because it determines your mail order pharmacy. So if I need to re-enroll you in a new one, I need to know about it. And so many of them were just like, oh, well, but I really like my one I have now. I've had it for 10 years. And so I'm sticking with it. And the first thing I would always tell them is, I would love to help. I would love to talk about this more and try to find a way for us to do a little research for you. Because again, having insurance doesn't mean that your care is actually more accessible or cheaper these days. There's a lot of ways in which monies that are supposed to be going toward your care are going into the hands of these entities and elsewhere. And that is why it is something that really should be researched every single year. Nothing about our industry and our system is consistent and transparent and right. There's a lot going on behind the scenes that patients and a lot of our Medicare patients didn't realize. So a lot of them too didn't get in contact with us, didn't see our communications, stayed on an Express Scripts related or associated plan, and now have either had to move to a different pharmacy or have to fill things out of pocket at our pharmacy in order to be a patient of ours. So yeah, but that's a great question. And I'm sorry that the answer isn't like, right, cut and dry. It is very complicated. And I think as patients ourselves, sometimes there's very little or only so much that we can do, but it is something to make note of and make sure that you're doing the research where you can, if able. And like I said, also, when stuff that happens to you is not okay, is violating your patient rights, like your plan steering you to a particular pharmacy or forcing you to go mail order, that is something that you can do something about, which is reporting that to the appropriate entities. And that's actually something we have info about on our website too. But yeah, does anybody else like in the chat or, I mean, I know Lori, you've asked a couple of different questions, so I can always elaborate on those if nobody else has a question right now. Okay, so the first thing that Lori had asked is, she said, I don't understand how patients are being forced to take more expensive medications. To me, it seems formularies do not cover the more expensive and rather approve alternatives that are less costly. Patients may need to do a prior auth that is correct to try to, or should try for the preferred med and may or may not even get coverage after that. And so I commented too, but I'll say, that is not always the case. Like, we can tell you that there are so many situations in which my patients are being forced to use brand name Novolog, brand name Lantus insulin, a brand name inhaler, where a generic alternative that is far, far more cost effective does exist, but it's not on their insurance's formulary. And that's because PBMs, because they negotiate with drug manufacturers and keep those rebates for profit, they are incentivized to include the drugs that lead to rebates for them from the manufacturer on formularies. And so that very commonly forces patients and forces us to fill the brand name version of a medication when it's really, there's no reason for it. There are certain cases in which a patient knows because they've tried, right? Or certain types of medications like CNS agents where a brand name drug can work better for a patient's body. But those situations are very rare. By and large, right, the whole point of generics is that the manufacturer has been given their set amount of years where they get to be the only one producing this drug and selling it as it's on patent. After that time is up, it goes generic, and the cost of that medication starts to go down and its accessibility starts to go up. Another kind of related thing is, so for example, Eliquis, which I'm sure at least some of you have heard of, right? It's one of the new blood thinners that we're moving people to in place of warfarin, because warfarin's such a pain in the butt to be on. Eliquis and Xarelto are kind of the two main ones, maybe the only two brand. They are both brand and still on patent, and so their manufacturer is the only one making them. They're very expensive. If we filled a month's supply at our pharmacy, it'd be about a $550 more for 1 month of Eliquis for a patient. I regularly, doing mail order for patients, see copays of $500, $600, $700 throughout the year for a 3-month supply once they've hit their deductible. But that's kind of, so in a related way, but not exactly the same way. And this is how the FDA is in some ways complicit in all of this going on and in PBM abuse, is that they, for the manufacturer of Eliquis, recently, within the last few years, granted a patent extension. Nobody knows why. We are not sure. And so my patients on Eliquis all the time say, oh my God, when is this going to get cheaper? Like soon? And I tell them, well, it's actually already supposed to be generic. It is a medication that in other countries and in this country too is supposed to be generic and off patent. That time frame that the manufacturer gets after marketing a new drug has already passed. But for unknown reasons, the FDA granted their patent extension. So the manufacturer of Eliquis gets to keep selling it at a very, very, very high cost. And my patients have to continue paying for it. And right, especially relevant when, for example, these new brand name blood thinners are, like I said, a great alternative for patients that have been taking warfarin, which is a really hard drug to be on because it requires so many visits and blood draws and so much monitoring. We have the opportunity to, for a lot of patients, increase their quality of life, especially if they're older or not as mobile or require right transport to all of these appointments they'd otherwise be going to. But again, they're going to have to keep paying through the roof for it for nobody knows what reason, other than the FDA granted a patent extension until 2028. And so that's the unfortunate way in which like our federal government is actively complicit in this problem too, and also non-transparent about it. And then Lori also asked a great second. Oh yeah, go ahead.
I can just jump there. So the bill that passed the House, the U.S. House before Christmas, and is now sitting in the Senate, the PBM reform bill for Medicare and Medicaid. One of the provisions in there is to uncouple the PBM's reimbursement or the PBM's take or pay from the cost of the product. And so that will be a huge piece in getting away from them forcing brand to be dispensed when there are generics available. So Advair is a great example. So an Advair 500 inhaler is about $480. We can buy generic Advair inhalers right now for $48 wholesale. And so that's the swing we're talking about. And they continue to force Advair brand because they can make so much more money on that rebate and such from the brand manufacturer. They can't make any money off of $48. They can make a lot of money off of $480. And so those are the things that are going on. But the current bill that's in Congress right now is to uncouple or remove the reimbursement to the PBM from the cost of the product, which will be a huge step forward in bringing some transparency into this arena.
John, do you know where our senators stand on that?
You know, we're talking about Tina Smith and Amy Klobuchar. Yeah, I mean they're both on board for this.
Okay.
To my knowledge, they haven't signed on to the bills, but you know, in the House, bills can have, I think, unlimited authors, and in the Senate, it's a whole different ballgame. But
Right.
yeah, I mean, you know, there's just so much anti-competitive stuff going on in this arena right now. I'm actually signing on as a plaintiff on a class action lawsuit against Express Scripts for price fixing. I mean, we know they have contracts with other PBMs that don't have market share like they do, and they're forcing their pricing structures onto these other PBMs as a way of getting them some money. You know, so it's like they're just taking over more of the market without taking over more of the market. I mean, and we know they're fixing prices behind the scenes. I mean, this is a couple $100 billion lawsuit, and you know, I'm going to be a plaintiff on it very shortly here. But I mean, they have to be stopped, or we are all in trouble.
Lori, you also had another really great question I wanted to address. You said, how do players such as AARP discount cards, GoodRx, and other such programs fit into this picture, which I'd love, Dad, for you to talk about. And just to clarify, in pharmacy, a manufacturer's coupon that's coming directly from the manufacturer of the drug is a different thing than these discount programs that we're talking about. We do accept manufacturer coupons at our pharmacy for patients who qualify and are getting these really expensive drugs that the vast majority of Americans cannot afford or shouldn't be expected to pay for. We do not accept discount coupons like commonly referred to GoodRx at our pharmacy. Dad, do you want to talk a little bit about that?
Yeah, so the manufacturer coupons, in fact, with Medicare recipients, they can't use them. So you get prescribed an expensive drug and you find a coupon for it, you bring it in the pharmacy, you're on Medicare, you can't, it's illegal to use that card. You have to pay your $400 copay.
Okay.
So there's a problem there. And then the GoodRx and the single care, and there's a whole myriad of cash discount cards or whatever. They're not really tied to anything other than stealing money from the pharmacy. And so those couple prescription tags that Hildy showed earlier in the presentation, with the -$7 and on those two health partners claims, that's going on all day. That's in fact GoodRx on the backside of a health partners claim, taking $7 from each of those claims for doing absolutely nothing as contributing to the healthcare system. They're just in there taking money, and their PBM MedImpact. So when somebody walks into a pharmacy with a GoodRx card, that card is transmitted or processed over the PBM MedImpact's network. And so MedImpact happens to be Health Partners pharmacy benefit manager. And so when GoodRx got busted a few months back by the FTC for basically selling 51 million people's private information to anybody that wanted to pay for it, and they fined them $1 million and said, stop doing that right now. They just went behind the scenes, hooked up with MedImpact, their benefit manager, for their card, and said, how can we work out a deal where you get some and we get some? And so that $7 is, I believe, being split between the two entities. And that's 1,000, I mean, it's just 1,000% price fixing and illegal. And so we are going to call them on it, and they are going to pay.
And the way that he has figured that out is because he obviously called to investigate why we were having negative reimbursements on prescription claims since the start of the year, and has through multiple conversations actually gotten this information volunteered from a MedImpact employee. So this is something that they seem to think we don't fully glean or understand what's going on, and they're trying to assuage his concerns about his pharmacy to the point where they offered to actually like turn off those negative reimbursements just for our pharmacy, which of course, Dad, you care about like the whole system as a whole, not just the survivability of our pharmacy. And so they continue to give him information, essentially being like Comcast or another cable provider saying, we'll give you, sorry, Mr. Hessian, that you're upset with your service. We'll give you a better package, or we'll give you a discount to make it more like within your financial range, what you're looking for. And then he's turning around and we're sharing this information widely with all of our buddies in independent pharmacy and getting as much information as we can to glean what exactly is going on so that we can use it when we hold them accountable in whatever means we're able to do that.
It'll be
It's been a wild, yeah, it's been a wild ride since the start of the year. So Jan, a lot of politicians take credit for insulin for $35. Is that true or a later time? Do you mean like later time for the question?
Oh, is,
We can definitely talk about this.
oh, can you hear me?
Yeah.
Is it something that is gonna happen 2025, some other late date? Cause boy, my diabetic husband has not, his insulin has not been 35.
Not, I mean, yeah, it may depend what product he's on.
Yeah,
But like your typical Novolog, Humalog, Lantus, you know, what we would consider to be insulin, there are diabetic injectables that are not insulin. And
right.
so, and here's the other problem with that. So Congress sets this new provision that, you know, insulin can't be more than $35 a month. That's great. You know, they think, oh, we've solved the problem. Well, here's the problem. The patient pays only $35 a month, but the pharmacy is still $38 underwater on the cost of the product. I mean, it hasn't solved our side of the fence in making sure that we get reimbursed appropriately for what we're dispensing. So the focus up until now has always been on how much will the patient pay? How much will the patient pay? How much will the patient pay? Can we lower patients' prescription drug costs, et cetera, et cetera, et cetera? And no focus or no thought about the pharmacy network where these patients go to get their medications. And so at some point, it doesn't matter if it's free to the patient. If there's nowhere to go to get it,
Yeah,
what have you accomplished? Who are you helping? You know, they're looking right past the network of pharmacies. And I'm telling you, 2024 is going to be a year of reckoning for retail pharmacy. I mean, my estimate is somewhere between 6,000 and 8,000 pharmacies in the next 6 months are going to close. Many of them probably in the next 3 to 4 months. I know I talked to a pharmacy owner on the east side of St. Paul. He called me on the 10th of January. He said, I don't know what to do. I said, what's going on? He said, my gross profit since January 1st filling prescriptions is 8%. Well, I don't know if anybody has been in business. If your gross profit goes below 20%, you can't pay your bills. You know, you're tight. If it goes below 18, 17, I mean, you're paying your vendor when they drop off your goods. You don't have any credit anymore. I mean, that's where you're at. He was below 10%. And so, unfortunately, he's probably not going to be around long. But this is where we're at. And many people, including our leaders, have no idea that this is where we're at.
And notably, this gentleman's pharmacy is a big provider of pharmacy care in the Hmong community in St. Paul. And so it's again, and it's kind of hilarious because NCPA, I mentioned them in my talk at some point, the National Community Pharmacists Association's kind of like one of our representative bodies nationally. We got an email recently about from an independent pharmacist we know who had been in direct contact with them, and they were telling this pharmacist that, you know, we have been given tools now and a way to submit complaints specifically about this problem regarding Medicare patients to CMS, like an email and a form and everything. But this pharmacist was told by NCPA, remember, they don't want to hear that you're underwater on claims and losing money. They want to hear why it affects patient access. I don't know why it's so complicated for them to grasp the idea that if a pharmacy doesn't exist for the patient to go to, there is no pharmacy to access. I mean, it's math that my 21-year-old sister could explain to a legend. You know what I mean? Like, it's mind blowing, but we're not supposed to complain that we're not getting paid, or in some cases, like I was talking about with my mail order patients and these expensive brand name drugs that we're actively moving out of our pharmacy so that we don't close, paying to do our jobs. We can't stay open and we can't serve patients. Like, it's that simple. But they has specifically told NCPA to tell all of us that they need it put into language about patient access. Well, pharmacy closes, no pharmacy to go to. I don't know what else you want me to say. If it takes more words than that, then you need to go back to school or something. And also, like, we have a job to do and problems to solve. So let's like keep moving on this and get past the semantics of it. Yeah, thank you, Cami, so much, and great question.
I think we are gonna end up
Yeah, I
stopping
know
now.
we're far over
And
time.
we'll be sending out a PDF of the slides, and Hildy also prepared a fact sheet for us, so I'll send that out too. You know that I'll send out the evaluation form, and then everything will come to you after you fill that out, and that's it. But I just want to say, the first time I went to a day at the Hill, I went home and I said, boy, we need to elect smarter people than we are. And we still need to elect some smart people. So, because pharmaceuticals aren't, pharmacies are different than pharmaceuticals, and PBMs are different. I mean, they should be able to figure that out. So
Yeah.
we need to get out the vote for smart people.
Yeah,
And thank you so much, Hildy and John, for all that you're doing, and for making the complex understandable. So I really, really appreciate it.
it's absolutely our pleasure. We want to talk to everybody who wants to listen. So thank you so much I know that this stuff can seem boring and so complicated that you just kind of want to quit listening about it, but it's like I've tried to explain, it's really fundamental to our crumbling health system. It's not just about filling prescriptions, it's about everyone.
The feeding trough of healthcare.
Yep. And if we don't stop them now, it's just going to get even gnarlier. And I just wanted to quick say, you had asked like how our legislators are supportive of this. Like, yeah, it aligns with their policies, but the last time I updated our legislative action page, it was probably a month or month and a half ago at this point. Tina Smith and Amy Klobuchar hadn't co-sponsored any of the bills that were in the Senate. Betty McCollum had only co-sponsored one that was in the House, in our neighborhood anyway. She's our rep. So despite the fact that it aligns with their policies and they say that they understand, we still need them to take action, even in Minnesota, in this place where we can often take advantage of our legislators supporting progressive reform in healthcare like this, right? So there is work to be done, definitely.
So calls to our senator's offices will be a good thing.
Yeah.
Thank you so much, everyone.
Yeah, thanks everyone. Good night.
Thanks.
Happy January.